All right, so now we're moving on to block 3 for medical, and we have a acronym for that. And your acronym is going to be FIT, which is FIT. So F stands for field impression. So we'll talk about that in just a minute. I stands for interventions. And T stands for transport. But this is our second transportation, so we'll talk a little bit more about what that means too. So let's start with field impression first. So with field impression, you guys are basically stating in just 1 or 2 words what you think is going on with the patient. Okay, so this is what you think is going on with your patient. This is not a diagnosis though, okay? So what do I think is going on with my patient, okay? Because we're going to base this treatment off of this. So again, this isn't a diagnosis because we don't diagnose in the field. We don't have the diagnostic tools to do so. So that could be as simple as, like an example would be that my field impression is I feel like the patient is having cardiac-related chest pain, or I feel like the patient is having asthma exacerbation, or I feel like my patient's possibly having a stroke. Those would all be field impressions, okay? Then we move on to interventions. What are interventions? So interventions can include medications that we may assist our patient with or give to our patient. So of course we know oxygen is something that we could do without calling medical control, but a lot of your other medications you have to call medical control before assisting with, okay? So that would be all of our medications. So that would include aspirin, nitro. You guys can do albuterol for your asthma. Okay, you guys can do an EpiPen. You guys can also do oral glucose, activated charcoal, and also Narcan, okay? Some of these you guys don't actually have to call medical control for. Others you do. So please make sure that you guys at least contact medical control and say, hey, I'm going to go ahead and either administer or assist with this medication, okay? Aspirin and nitro you're assisting with. Unless you work for an area that carries aspirin, then you would call medical control before administering it. Albuterol is going to be the patient's albuterol inhaler, so you're assisting with that. EpiPen, again, you're assisting that with the patient's medication, unless, again, you work in an actual area where they carry Epi on the ambulance. Oral glucose will be found on the ambulance for you, but you still have to call medical control before giving it. Activated charcoal, at least in San Bernardino County, you will not find this on our ambulances, but in other areas you may. So make sure you understand activated charcoal, but that is carried on the ambulance. Again, you have to call medical control before giving it. And then Narcan is carried on the ambulance. Again, you have to call medical control before actually giving it, okay? So all these medications either may be the patient's or may be found on your ambulance, but you have to call medical control before assisting any of them, okay? Other interventions can be as simple as a blanket. It can be as simple as a position of comfort. That's what POC stands for. So maybe placing the patient in a tripod position or trying to help them get into a high Fowler's position because they're shortness of breath. Maybe putting them in a semi-Fowler's position. So maybe the best position that's the most comfortable for them. Okay, and then if you did oxygen, that's interventions you've already started prior, like we talked about in block 1. So that's already an intervention you're doing, okay? So those encompass all of your interventions. Then we get to second transport. What does second transport mean? Second transport means that if I decided my patient was a stay and assess, at some point I have to transport the patient. I can't stay at the patient's house all day, so we're going to transport. Let's say that I said originally that my patient was a load and go patient. Then when we get to second transport, we're just going to say we're already en route to the hospital, so we're just going to continue on with our assessment. So that is everything that encompasses block 3. Okay, so make sure you guys remember that if you are going to assist a patient with a medication, after you get medical control's approval, please make sure that you guys are doing your rights and your dice, okay? So make sure we're doing the rights and the dice. That's really important to do with your medications prior. So remember what we have is we have right patient. So I'm just going to write the ones over here, but remember these are your rights. We're going to have right route. So what is the route we give it to the patient? The right medication. Make sure you have the right medication. Is it the right time to give it to the actual patient? Is it the right dose? So make sure that you verify your dose. And then make sure we do the right documentation, okay? So we want to make sure that we document appropriately, okay? And make sure that you guys do ask the patient any allergies that they may have to any types of medications, okay? And then for DICE, I'll go ahead and write it up here for you guys. So remember your DICE has 2 things for each. So the D is drug and dose. Again, make sure we're doing the right medication and the right dose. We have indication. So is this medication indicated for the patient? What is the integrity of the medication? Is it intact? Is it cracked? Those are important things that we need to find out. Clarity, most patients' medications should be clear unless it is a medication that has a color to it. But check the clarity of it. Make sure you don't have any floaties or anything in there. And then contraindications. Okay, so remember, indications means the reason why we do something. Contraindication means reasons why I would not do something, okay? And then we have our expiration date, okay? So expiration date and then our expected outcome. What is the expected outcome that we're expecting by giving this medication to this patient, okay? So make sure you guys are checking your rights and dice before you're giving any medication. All right, so the very last step of your medical assessment is our block 4. This block I call our reassessment block, okay? So basically we're reassessing blocks 1, 2, and 3, okay? But only certain parts of block 1, 2, and 3, okay? So when I think of reassessment, there's actually 5 things that you guys are going to reassess on your patient, okay? So the way I think of it is I go back to block 1. What in block 1 can change, okay? So I know right off the bat that AFPU can change. I can have a patient go from alert to verbal, or a patient from alert to unresponsive. I can have a patient that was initially unresponsive, and maybe now that we've administered a specific type of medication, now they're more verbal, okay? So your AFPU can change. Another thing in block 1 that can change are your ABCs, okay? So my airway status can change, my breathing status can change, and my circulation can change, hopefully for the better. But if it is getting worse, then we need to basically start our assessment from the beginning. Anytime we have change in patient condition, we're going to start from the beginning and reevaluate our patient, okay? Then we move into block 2. What in block 2 can change, okay? So we know that we check the rest of our vitals. So vital signs can change, okay? That's why we take those initial vitals, which is our baseline. Any vitals after those initial vitals are what we call trending vitals. So we're constantly comparing and contrasting them to see if there is hopefully we see a difference that we want to see. Like if I had a high respiratory rate, hopefully that it's starting to decrease for that patient, okay? We don't want it to be going the opposite way. So you're going to reevaluate vitals. Again, first set of vitals are baseline. Any vitals after that first set are trending vitals. Then you're going to re-ask your P, Q, R, and S. So this is from my OPQRST. I don't ask O again because onset's not going to change. What they were doing doesn't change. When it started, doesn't change. But provocation, quality, radiation, and severity, all of those could change. So we're going to ask them again. So last time you said this, now how is your chest pain feeling now? Last time you told me that it felt like heavy pressure and an elephant sitting on your chest. Can you explain to me how it's feeling now? Okay. And then the last thing we're looking at in block 3, what in block 3 can change? And what can change is our interventions. Okay. So maybe we decided initially to put our patient on an automated breather mask. My patient's improving. So now I can drop my patient down to a nasal cannula. Or maybe my patient started having respiratory distress when they didn't have that initially. So maybe now I have to increase the O2 or put them on O2. So interventions are constantly changing, okay? And then the very, very last step of your whole entire medical assessment is that verbal report when you get to the hospital, okay? So when we get to the hospital, we are going to give an accurate verbal report. It's pretty much a summary of our whole entire assessment, okay? So it's really important that at this time we are doing that summary. We are then running through, okay, so this is how the patient originally presented. These are the things we did for our patient. Now this is how our patient's presenting, okay? When it comes to this reassessment block, not so much your verbal report because you give that one time and then that's it. But this reassessment block as you're transporting to the hospital, if it is a stable patient, you're going to be doing this reassessment block every 15 minutes. If it is an unstable patient, we are going to be doing this assessment block or reassessment block every 5 minutes, okay? So just know that this will constantly be happening every 15 or every 5 minutes, depending if your patient is stable or unstable, okay? And remember that your verbal report's different than your radio report, okay? Your radio report, you should have been given to the hospital around interventions. Once you've kind of figured out what's going on with your patient, after you do that field impression, you're going to go ahead and call medical control, tell them what you have to request for any interventions that you may need. So the verbal report's pretty much a summary of everything, where your radio report just focuses on what you have and what additional interventions you may need for that patient, where the verbal report, you've already requested for those interventions. Now we're stating, hey, this is what we had, this is what we did for the patient, this is how the patient's now presenting. Okay? And that is the end of your medical assessment. All right, so for block 3, we're starting with field impression. So the field impression that we're getting from our patient from all the questions we asked prior is that my patient's having some type of cardiac-related chest pain. So that is my field impression of my patient. So I'm going to move on to interventions. As we can see, we already put the patient on high-flow oxygen via non-rebreather mask. We have the patient kind of in the position of comfort for them. We found out during our sample history that the patient does take aspirin and nitro. So at this point, I would call the hospital. I would go ahead and give them a radio report. And in this radio report, remember, you do not state the patient's name at all. So I'm going to give them a radio report, let them know what I have, what I'm seeing, and the different interventions I'd like to do. So in this case, the interventions I would like to do is aspirin and nitro. So of course, before I administer aspirin and nitro for this patient, I'm going to ask my rights and dice, or check my rights and dice. So I'm going to go ahead and ask the patient, what's your first and last name?
Ron Burgundy.
All right, so this medication is prescribed to Ron Burgundy, and this medication is as well. So with these medications, we'll start with aspirin first. So we have the right patient. We have the right medication. This is chewable aspirin is what pretty much is carried. We know that it's 81 milligrams per tablet, and we're going to do a total of 324, which is our dose, which would be 4 baby aspirin. We know that it's the right time to give it to the patient because the patient is experiencing a cardiac-related chest pain. And we also know that it is, we got to make sure we do the right documentation for this as well. And again, we verified that it was aspirin and it did belong to the patient. Sir, do you have any allergies to any medications at all?
I have no current allergies.
Okay, so we know that the patient has no allergies to anything, and you have taken aspirin before?
Yes, ma'am.
No problems with aspirin at all?
No.
Okay, so then I can dice it too, where I can make sure, again, it's the right drug. It's aspirin, make sure it's the right dose, which would be 324 milligrams. We're going to check the integrity of it. It looks good. It doesn't look cracked or broken. The indication, it is indicated because he has cardiac-related chest pain. We're going to check the clarity. So this doesn't really have clarity, but we'll check the pills and make sure they're not like a different color that they shouldn't be. And then also check contraindications. So any recent bleeding at all that we need to be aware of? Any ulcers?
No, nothing.
No. Do you take other like blood thinners or no?
No.
No other blood thinners. So we're just making sure that things that could be contraindicated to give this medication is not contraindicated. And then, of course, we're going to check the expiration date on it, make sure it's not expired, and then our expected outcome that hopefully, remember that aspirin is an antiplatelet aggregate. So it's definitely going to help prevent from additional clotting from happening. And then, of course, our nitro is what's going to actually help with the vasodilation. So now I'm going to make sure this is the right medication. It is nitro. Again, what is your first and last name?
Ron Burgundy.
Okay, Ron Burgundy. So we know it's the right patient. We're going to make sure that we give this patient sublingual. That would be the right route for this. As well, the right route for your aspirin is PO. And then we're going to make sure it's the right time. Again, the patient is having cardiac-related chest pain, so it is the right time to give it to the patient. Then we're going to make sure that we have right documentation. So we're going to make sure to document it correctly. And then you said you had no allergies. Have you taken the nitro before?
I've used it once or twice.
Okay, and no issues with it at all?
No.
Okay, all right. So, so we pretty much have, again, you want to make sure you have the right patient, the right medication, the right route, the right dose. So dose for nitro, of course, is 0.3 milligrams. We're allowed to give that dose up to three times, but it has to be 5 minutes apart for each dose, making sure it's the right time and then right documentation for the patient. And we verified that he doesn't have allergies to either one of these medications. He has taken them before without any issues. So we know that. And then again, go through the DICE, so drug and dose. So again, drug nitro, dose 0.4 milligrams. Integrity, it looks good, it looks intact, doesn't look cracked or anything. Indication again would be cardiac-related chest pain. Clarity, it looks clear, it looks like it's the right color. I don't see any floaties in there or anything. Contraindication, so we're going to ask any kind of recent head injuries lately.
No, nothing major.
Okay. Have you taken Viagra in the last 24 to 48 hours?
No.
No?
I have not.
Okay. And then at this point, another contraindication would be hypotension. We checked his blood pressure and his systolic is above 100, so we don't have any contraindications. Again, we would check expiration date, and then we would check, hopefully our expected outcome is that the chest pain would be relieved at least a little bit, or hopefully entirely. So once we make sure that we got clarification from medical control that we can assist with these medications, then we would go ahead and do so. So for the baby aspirin, you would basically, you would have a gloved hand, of course. You would take the aspirin, you'd hand it to the patient. You would tell the patient then to chew it. So tell the patient put it in their mouth and chew it. So the patient does so. We always give aspirin before nitro because we go least invasive to most invasive. When you do the nitro, pretty much you want to spray it off to the side to prime that pump. Then you would have the patient open their mouth, lift up their tongue, and then spray it underneath their tongue for administration for that as well. Okay, so after you give those two medications, you got to give it some time to actually work. So at this point, we determine our second transport decision. He was a load and go from the beginning, so he is still a load and go. So we're doing a lot of this stuff already in the back of the ambulance. And that is what block 3 looks like. All right, so now we're moving into block 4. So remember what I told you guys before, this is your reassessment block. So we're going to reassess everything with our patient, starting from AFPU, ABCs. We're going to do all of our vital signs. We're going to do our PQRS, our interventions, and then we'll go ahead and do our verbal report. Because this patient was unstable, we would do this reassessment every 5 minutes. If he becomes a little bit more stable, then we may be able to extend that reassessment every 15 minutes, okay? So now that I'm still talking with my patient, I'm noticing my patient's tracking me, so he is still alert. So I know he's still alert on the AFPU scale. Okay, then I'm going to move to ABCs. How are you feeling, sir?
Much better than before.
Okay, so he's talking to me, so I know his airway is open, clear, maintainable. There's no need for suction or airway adjuncts. So I'd move on to breathing again. So I'm going to go ahead and I'm going to get lung sounds. I'm going to request that my partner places them on the pulse ox. And as soon as I'm done, then I'll have you count respiratory rate for me, okay? All right, sir, since the way you're sitting, I'm just going to go ahead and I'm going to listen to the front of your lungs. So do me a favor and take a deep breath in and out. And then again, in and out. And then I'm going to go right here underneath your arm to the mid-axillary. So in and out. Okay, and one more time. In and out. Okay, so my lung sounds are nice and clear. My partner's going to go ahead and place my patient on our pulse ox. Now, he is on a non-rebreather mask at 15 liters right now. Sir, can you tell me how your respirations feel? Do you feel like you're having an easier time breathing?
Way easier.
Way easier?
Yeah.
Okay. So we're going to go ahead and we're going to bump you down to 10 liters per minute and maybe decrease some of that oxygen a little bit. So we look at the pulse ox reading, and on the 15 liters, he's sitting at about 99, 98%. But we're going to bump it down to 10 liters, and we're going to go ahead and see. We'll continue to evaluate his respirations and his pulse ox to make sure we don't have significant drops in those when it comes to the pulse ox or an automatic increase in that respiratory rate, because then we'd have to increase our oxygen again. So we'll just leave the pulse ox on the patient so we can monitor him. My partner right now is counting respirations. I can see now that we actually have a pretty normal depth for this patient. He doesn't seem labored at all, so I'd say he's more non-labored. So again, we would continue to monitor this en route to the hospital because changes can happen. So as soon as we get that nice respiratory rate, then we'll move on to our circulation because we've already kind of reevaluated our oxygen at this time.
Got a respiratory rate of 17.
Okay, so we have a respiratory rate of 17, which sounds good. I'm going to go ahead and have my partner here assess the pulse. So if you could get, I'll let you go on this side since we have the pulse ox on the other side. So if you can get rate, rhythm, quality for me, I'll go ahead and start working on the rest. So I'm going to go ahead and get skin signs. Sir, are you okay if I paste the back of my hand to your forehead?
Yes, of course.
Okay. So we are warm to the touch. Before he was pretty diaphoretic, but we're warm to the touch. It looks like we've kind of cleared up that diaphoresis. So his actual skin moisture may be a little moist, but it's not diaphoretic like it was before. And then we also noticed that his skin color is starting to improve. He was pretty pale to begin with, and that's starting to improve for us a little bit. Okay. Then I'm going to go ahead and I'll assess a quick cap refill. So it looks like we have better cap refill. Before it was slightly delayed. Now it's actually pretty immediate, which is good, which means we've got some good perfusion going on. And then I'm going to go ahead and assess for life-threatening hemorrhaging. I don't see any. What do we get for that pulse?
Pulse of 90.
Awesome. So we have a pulse of 90 before it was actually over 100. How did that pulse feel?
Strong.
Strong?
And regular.
Oh, perfect. Okay. So we have a strong and regular pulse. So we have everything in our ABCs pretty much taken care of. So now we can move on to continuing our vital signs. So I'm going to have my partner at this time go ahead and get a blood pressure for me. So an auscultated blood pressure and then pupils. So let's start with blood pressure so I can ask the PQR questions again. So sir, I'm going to ask you a couple questions like I have before. So last time you said the thing that makes it feel better and worse was pretty much the oxygen and the position that you were in. What would you say makes it better or worse now?
The oxygen definitely helps.
Okay.
And just overall being relaxed.
Okay, what about the medication that we assisted you with?
Oh, that's made a dramatic difference.
Okay, all right. So you're seeing an improvement after that medication as well. Okay, perfect. So we're seeing improvement with the treatment that we provided for the patient. So then we're going to move on to our Q. So last time you described it as a heavy pressure, like an elephant sitting on your chest.
Yes.
How would you describe it now?
After the medications, it's a 2.
No, but how would you describe it? So you said last time heavy pressure or like an elephant sitting on your chest. How would you describe it
I don't
now?
really feel anything now.
No, you don't have the pressure anymore?
No, I don't feel any weight on my chest.
Okay, all right. What about radiation? So last time you told me that it radiated to your jaw and your left arm. Are you still having that radiating pain to the jaw or arm?
No, I don't.
No, neither one?
Neither.
Okay, all right. And then last time you told me it was a 9 on a 10 scale. What would you rate it at now?
A 2.
It's a 2 on a 10.
Yeah.
Okay, so the patient still has pain. So when it comes to our interventions, we could definitely give another dose of nitro if we felt it was needed because he still has a 2 on a 10. We're not at a 0 yet. but we definitely have decreased it significantly. But it does depend on his blood pressure. What do we get for that blood pressure?
114/80.
Okay, 114/80, so our systolic is still above 100. So we could go ahead and administer another dose of that nitro. So we're going to go ahead and administer another dose of the nitro because we're still at a 2 out of 10. But I did want to ask you, because side effects of nitro is kind of a pretty extensive headache. Do you feel that headache right now, or is it kind of subsiding?
I feel a slight headache.
Slight headache? Okay,
Slight
what about,
headache.
did you feel burning under the tongue after you took the nitro?
No, not this time around.
No? Okay. So normally a side effect is burning under the tongue, so we'll just have to verify and make sure your medication's still good, because we want to make sure you have that burning under the tongue, because that tells us that it's actually working, okay? So let me know when we give it the second time if you have that burning under the tongue, so that way we're aware if it's working correctly or not, okay? All right, so our blood pressure is still in normal limits, so I'm reevaluating my interventions. I dropped the O2 down already. It looks like we're still satting pretty good. Patient seems to, the respiratory rate doesn't seem to have increased, so we're doing well. So, sir, we're going to go ahead and do another spray of your nitro. So we just have them open their mouth, lift up their tongue. We would spray it in there. And again, we would reevaluate that patient in about 5 minutes. So did you feel the burning under the tongue that time?
I do feel the burning
Oh,
now.
okay, okay. And is the headache kind of getting worse all of a sudden for a short time?
Yeah, definitely.
Yeah, I'm sorry. Unfortunately, that's a side effect of nitro. So I've reevaluated my intervention. So I'm going to continue to do this full reassessment en route until I get to the hospital. And then once I get to the hospital, I'm going to give an accurate verbal report to the bedside nurse, as well as if the physician's at bedside as well. So that, again, like I told you guys before, that's a full summary of what we found, what we did for the patient, and how the patient responded to our care. And that would be the end of your medical assessment.